Ladies and gentlemen, the last lecture of this session features none other than Dr. H K Chopra, the organizing chairman of this 9th wccpci, and he is the incoming president of Cardiological Society of India. Currently, he serves as the chief of cardiology at Mulchan Medicity in New Delhi.
Chairman, sir, fellow colleagues, ladies and gentlemen, TNK in STEMI is a subject given to me. Time to reflect is now. What should be the strategy? Time delay is known to every one of us. Where does the time delay take place? Is it a home to hospital? Is it door to needle time or door to balloon time? Delays everywhere. There is no protocol being followed worldwide. What should be the exact strategy? Why does it happen? Lack of awareness about the symptomatology, lack of interpretation by the patient and the GPs, poor transport system, and the PCI is only effective in 10% of patients of STEMI. Consensus by JAPI is very clear that PCI in 3 to 24 hours, but first 2 hours, TNK is the answer. STEMI guidelines, there is a huge gap between the guidelines and the clinical practice. And I firmly believe that for practice purposes, guidelines are not guidelines. STEMI mortality is very high. We should always consider in our mind. Why pharmacoinvasive approach for STEMI should be known to all of us today, and we must protocolize in our country at least. If you really want to use early TNK, we can abort the myocardial infarction in first 40 minutes. We can make a larger infarct to a small infarct. We can make a transmural to a subendocardial infarct. We may prevent reinfarction, and we can prevent the extension of infarct. The golden hours concept should be known to everyone. 0 to 1 hour, we can salvage 65 people per 1,000. 3 to 6 hours, 27 people per 1,000. It's a huge benefit. Primary PCI availability is only in 10% of individuals, even in the busiest centers. If I talk of Delhi, very, very busy. Transport system, very inadequate. I don't think primary PCI is the right answer. Mortality benefit of primary PCI are definitely known, but if the delay is more than 16 minutes, delay of primary PCI is more than 60 minutes, and it deprives the patient of other benefit, the mortality is going to be high. ACCHA guidelines are known to us that just a bolus of TNK may salvage the jeopardized myocardium. My main agenda of presentation is to highlight the efficacy and safety of TNK and to assess the successful thrombolysis strategy, the rate of TNK, and obtain the morbidity and mortality data. TNK and STEMI have a huge registry from India, and 15,000 patients has documented very clearly that it is the hypertension, as mentioned by Dr. Dedwania, diabetes mellitus, all are the risk factors dominant in our country. The usefulness of successful thrombolysis depends on the time window. It is the time which is the myocardium. First 3 hours are the most crucial hours. This is very clear to show that first 20 minutes to 40 minutes, if you salvage the jeopardized myocardium, we can easily abort the myocardial infarction. See the data. The data is very clear. If we show in first 3 hours and give a patient TNK, we can really salvage the jeopardized myocardium and increase the successful reperfusion. We can see here the mortality data is very clear. If reperfusion is achieved effectively and meticulously, in first 3 hours, the mortality can be reduced from 9% to 1%. It has also been shown that mortality can also be reduced even if it is given up to 3 to 6 hours. The STEMI data is very, very clear that morbidity and mortality high in STEMI as compared to non-STEMI. The morbidity is shown very clearly. If a patient is given TNK, there are minor bleeds. I don't think we should worry about the minor bleeds because we salvage the myocardium. We have a lot of myocardium which is functional. We salvage the tendency for VT. It is more common in the individuals who are more than 70, or if a patient got a CAD with a heart failure, or there is a reinfarction or ventricular tachycardia. Successful thrombolysis can also be achieved effectively in elderly patients. Concomitant medications in this registry has been shown here that most of the patients were on calcium channel blockers, beta blockers, nitroglycerin, low molecular weight heparin, and GP2B3 antagonist. This is the Italian registry data. 27,000 patients has shown very clearly the reasons for preferring thrombolysis with TNK can be well compared to PCI. TNK effectivity can be further enhanced by adjuvant treatment like clopidogrel or aspirin. This is the whole data. This is just to show the studies from 1999 to 2007, which has shown very clearly that the TNK is superior in first 2 hours as compared to PCI if the facility is not available. Reasons for preferring thrombolysis as compared to PCI, very obvious. ST resolution is very fast and very quick. As I mentioned to you, it can abort MI. It can reduce the morbidity and reduce the mortality. The potential of early reperfusion cannot be overemphasized. Very clear in this slide. Ladies and gentlemen, rapid diagnosis, early reperfusion are the real pillars of success in STEMI management. There should not be any conflict or fight. What should give first, PCI or TNK? The reason for using TNK is a class 1 recommendation in STEMI by ACCP guidelines. TNK recommendation in pre-hospital thrombolysis very well established by Vienna study, Mayo Clinic data, and the French Fast MI registry in 2008. Potential of 10 active places are known to all of you. I won't go to the details. It is just to be given as a bolus, and no hypertension, no allergic reactions, longer half-life, rapid action. And then we see here the potential of TNK can be dose adjusted according to the weight. Early and manageable bleeding complications. The agent of first choice for pre-hospital thrombolysis at home, in the ambulance, in the air ambulance. TNK is superior than STK, there is no doubt, so far as the fibrin affinity is concerned, and so far as the hypotension or antigenicity is concerned, TNK is superior. Even if you compare to LT place, TNK superior is given just a bolus dose in 5 seconds as compared to LT place, which is given over a longer period of time. And the plasma half-life is just 20 minutes as compared to LT place, 4 to 6 minutes. Ladies and gentlemen, only 4% of transferred patients receive primary PCI within 90 minutes. This is from the first medical contact. Thrombolytic therapy, whether we use first generation, second generation, or third generation is superior. See the level of evidence. The level of evidence is grade 1A so far as TNK is concerned, and it's almost grade 1B so far as retiplase is concerned. I will not talk about the other agents. These are data from United States. Only 20% of US hospitals have angioplasty services. We have with us the President-elect of American Heart Association. Let's see his viewpoint on this. In a place like USA, only 20% angioplasty can be done in a patient of AMI. What to talk of our country? Very difficult. To conclude, ladies and gentlemen, CST with TNK highly significant. In first 3 hours, there is a robust evidence. No conflict, no dispute, no confusion. CST rate lower in elderly and in patients with a past history of IHD. Overall mortality rate is significantly reduced from 9% to 1.69%. It is slightly higher in a delayed treatment elderly patient with a past history of IHD. Minor bleeds, please do not worry about the minor bleeds like a GI bleed, which can be easily taken care of. Overall morbidity benefit. TNK is an agent of first choice with no hypertension. Morbidity and mortality benefit cannot be overemphasized. What's the take-home message? The take-home message is health of millions is at stake with the rising meaning of STEMI in India, especially in a setting of metabolic syndrome. Early TNK administration in STEMI is the need of the hour. Very important message. TNK is very safe, very effective, and indigenously available in our country. DBT is minutes as early as 30 minutes, and DBT is 90 to 120 minutes. time to reflect TNK potential in STEMI is now, with a robust data available all over the world. Pharmacoinvasive approach is the only solution for India and not PCI in the beginning. Act locally and impact globally if you really want to create innovative protocols. Time has come, we have to create protocols in every setting what we do. No more fights. No TNK versus primary PCI. The solution is TNK and PCI together. Thank you very much for your kind attention. The pioneers of thrombolysis are known to us. Tillett, for the first time in 1933, brought the concept of thrombolysis in streptokinase. Professor C.P. Cannon brought the concept of IV streptokinase. TNK is the answer if you really want to salvage the jeopardized myocardium and reduce the morbidity and mortality by creating enormous EMS, emergency services. I was discussing with the President-elect of AHA, and I'm sure he's going to think on these lines to do something for India. Thank you very much for your kind attention.
Thank you, Dr. Chopra. Please have your seat. Ladies and gentlemen, we have 7 minutes for discussion for the papers. Over to the chairpersons. Thank you.
Thank you, Dr. Chopra, and also the rest of the speakers at this session for some excellent, excellent presentations. Dr. Chopra, you really hit the nail on the head when you discussed the importance of recognizing and treating acute myocardial infarction promptly. And as implied in your comments, we need systems of care to really effectively deal with this problem. We can't compare the United States to India, clearly, and that's really the point of your presentation. In our major cities in the United States, through programs from the American Heart Association, we have systems of care such as our Mission Lifeline, which effectively direct patients to hospitals in a prompt manner that are immediately equipped to proceed with PCI. But as you showed on your map, that's not available in rural areas. India is much like many of our rural areas where you don't have ability for prompt access to medical care. So I would agree with your final implication in that you need to set up systems of care here in ambulances before arrival to the hospital with prompt administration of TNK. And perhaps you can help lead that charge right here with our assistance.
Thank you. Thank you, sir.
I would like to have a few comments. Dr. Didwania's lecture stressed the relevance of metabolic syndrome and the development of diabetes as a very important risk factor in the development of coronary disease. About 30 years ago, when we look at the patients coming with coronary disease in our state, that is state of Kerala, most of the patients were below the age of, a good number of patients were below the age of 40, and majority were below the age of 50, and some above the age of 60. And a very important risk factor was smoking. And at present, the scenario has completely changed. Kerala, which can be considered as an affluent state, it goes in the direction of the Western world, where the people coming with myocardial infarction, most are above the age of 75 years, and diabetes and hypertension are the two major risk factors, and most of our patients with acute myocardial infarction are non-smokers. So it's very important that we have to stress the importance of looking at diabetes and preventing diabetes so that the melody of a coronary disease and acute myocardial infarction can be definitely brought down. I think it's correct that Didwani has brought out this point. Regarding the echo, I would like to have one or two comments. If you look at the indications for anticoagulation using the CHART or CHART-S2 VAS score, as Parashar has rightly pointed out, there is no parameter other than LV dysfunction to directly involving the thrombus formation in a patient with atrial fibrillation. Mostly it looks at the risk of developing a stroke, which can be due to a thrombotic stroke also, like diabetes, hypertension, all these factors. But if you look at echo, echo directly looks at the risk of developing a thrombus in a patient with atrial fibrillation, like looking at the left atrial appendage, its velocity, the left atrial size, left atrial volume. All these parameters are directly correlated with the development of thrombus in the left atrium. It's high time that we look at echo as the most important parameter to decide whether a patient should be on a long-term anticoagulation. I would like to ask one question to Dr. Parashar. We had been using the transthoracic echo, especially in those patients where the left atrial appendage could be very clearly visualized to assess the risk of thromboembolism, and only when we could not have a good picture of the left atrial appendage, then only we resorted to transesophageal echocardiography. Do you agree to this proposal, Dr. Parashar?
See, the left atrial appendage is a very complex structure. It is very highly variable in size, shape, number of lobes, and it is tubular structure, so you cannot see all the lobes and everything on a 3D echo. So you can presume by some of the factors which we have told, that this patient is not likely to have an LA appendage thrombus, but I think if the patient is in atrial fibrillation, you have to do a transesophageal echo and cannot exclude an appendage thrombus, mainly on a 2D echo, unless you may do some 3D echoes also.
But if you look at the right atrium, then the imaging of the right atrium is inferior with transesophageal. So do you think that it's important to look at the right atrium also, because now people are thinking
So
the right atrium also contributes to an embolic episode,
So
especially in the pulmonary system?
when we do an echo, we see all these structures also, then especially these, but I think the most commonest site is a left atrial appendage still, because it is narrow tubular structure, so still it's one of the most commonest sites. But there's no harm in seeing that, but the majority of, according to the literature, majority of the thrombi occur mainly in the left atrium and the left atrial appendage.
I'd like to ask one question to Dr. Chopra. Dr. Chopra, because the bleeding risk is very often highlighted, and in a patient who receives TNK, and you said that bleeding risk is very marginal. What is your experience comparing with SK and TNK? What would be the extra percentage where the patients with TNK can have a bleeding, especially intracranial hemorrhage?
I think it's a very good point and a practical point. We have a tremendous experience of using streptokinase from 1983 onwards. We were the first people in India who presented a huge data in Indian Heart Journal, which was published. And we find the prevalence of hemorrhage is very high in streptokinase. Antigenicity is very high. Hypotension is very high. It has to be given as infusion. They are the limitation of streptokinase. So far as the TNK is concerned, we have used TNK in a lot of patients. And our experience says the bleeding is only seen to a very small extent in elderly patients beyond 75 or 76 years of age. One. Number two, especially the people who are diabetics, where there are more angiopathies, they are more vulnerable to bleed. But we have not seen any major catastrophe so far as the TNK is concerned. And I think if I compare the benefit, which are morbidity and mortality benefit of TNK versus over the minor bleed, I think the TNK is superior. Minor bleed can be easily managed.
In TNK, do you recommend the same dose of low molecular weight heparin as
point.
we use in streptokinase,
Yeah,
enoxaparin with the same dose?
It's a very good point. We reduce the dose to half in elderlies. Those who are elderly patients, we reduce the dose to half. And we find the bleeding can be minimized when we give the half dose. At least we trigger the reperfusion followed by PCI in these patients.
Thank you.
I want to make one I just follow up on the comment regarding the thrombus in the left atrial appendage. I think both, you need to remember that both the transthoracic two-dimensional and the two-dimensional transesophageal echo are slice techniques, and both can miss thrombus in the left atrial appendage and may not be able to see all the lobes. So you really have to go for the three-dimensional echo, either three-dimensional transthoracic echo if the window is very good and you get good quality images, and if you don't get good quality images, then you need to go for three-dimensional transesophageal echocardiogram. It is very, very important to realize the slice-like nature of two-dimensional images.
Ladies and gentlemen, that's all we have time for discussion. May I now request, Professor Vijayaraghavan, please.
One of the points that we have to stress is that Dr. Devani has presented a very excellent presentation on the metabolic syndrome. We have to remember that the prosperity has not yet come, but the heart disease has really happened just before the prosperity. what happens in our population is that vast majority of patients who develop acute myocardial infarction are the poor farmers, the fishermen, the teachers, and the poor people. It is to these people, I would say Dr. Chopra suggested TNK initially as the best form of treatment, because many patients take more than half an hour, 1 hour to make a decision whether they can afford an angioplasty. We give only 15 minutes in our ICU. Make a decision and tell us within 15 minutes, if there is no decision, TNK will go in. That saves the patient.
Thank you very much, Vijay. Ladies and gentlemen, I now request our chairperson, Professor G. Vijayaraghavan, to please step forward and present a memento to Professor Prakash Dedwania. I would now like to invite Professor I.B. Vijayalakshmi to please step forward and present memento to Colonel S.K. Parashar. May now invite Dr. Mark Krieger to kindly step forward and present memento to Dr. Chopra. Ladies and gentlemen, that concludes the proceedings of this session. Thank you very much.